All right, let's jump right in. We're heading into some seriously high-stakes territory today. A little spot in the body called Calot's triangle. This is basically a surgeon's guide to the vascular surprises that can turn a totally routine procedure into a life-or-death situation in seconds. And this quote, well, it just says it all, doesn't it? It's blunt, but it is so true. In surgery, it's often the smallest vessels that pack the biggest punch. It really sets the stage for the kind of precision and pressure we're talking about here. So let's officially enter what we're going to call the arterial danger zone. I want you to think of this surgical area like a landscape. Every surgeon has a map, right? The one they memorize from textbooks. But as we're about to find out, sometimes that map is just dangerously wrong. Now, this is what the map is supposed to look like. This is the safe path. In a perfect world, the cystic artery, that's the one feeding the gallbladder, it just branches off nice and clean from the right hepatic artery, or RHA. It's predictable, it's what you're taught to expect. But here it is, the big question every surgeon has to be ready for. What happens when the body in front of you doesn't match the book in your head? What do you do when the map is wrong? Because that's the moment a routine day gets very, very interesting. And that brings us right to our first major hazard, a landmark that you will not find on that standard map. We're talking about the treacherous hump. It's officially known as Moynihan's hump. And what's so wild about this is it's not some new extra artery. No, it's the right hepatic artery itself taking this crazy winding detour. It gets way too cozy with the gallbladder neck, just hugging it. And here's why that's so terrifying. It literally looks like a prominent hump right where you're working. And because it's so close to the gallbladder, it's so easy to mistake it for the cystic artery. And if you make that mistake, if you clip that hump, you've just cut off the blood supply to half of the patient's liver. It is an absolute catastrophe. So if the first danger is seeing something and misidentifying it, our next one is all about what you don't see. Let's call this one the hidden branch. Yep, we're talking about a double cystic artery. So you find an artery, you clip it, you think you're done, but surprise! There's a second one lurking around back, usually on the posterior side. It's the classic surgical jump scare. Look, whether it's a true double artery or just some rogue posterior branch, the end result is the same. You've got bleeding from a source you thought you took care of. Now you're hunting for a mystery bleeder in a field that's already a minefield. It's a bad situation. All right, our last big danger is maybe the most deceptive one of all. It's a vessel that shows up where it has absolutely no business being, completely shredding your mental map. This is the artery from nowhere. This is something called a replaced right hepatic artery. So instead of coming off the proper hepatic artery like it's supposed to, the RHA just decides to sprout from a completely different vessel, the superior mesenteric artery, or SMA. And this, well, this changes everything about its journey to the liver. Because it's coming from the SMA, it takes this bizarre path. It comes in more from the side, more from the back, which puts it right in the line of fire. It's incredibly vulnerable. If a surgeon starts clipping things without a crystal clear view, what we call blind clipping, this artery is a sitting duck. Okay, humps, hidden branches, arteries from nowhere. This sounds like an anatomical nightmare, right? So how in the world do you navigate this safely? Well, there is a way. There's one single, unfailing compass you can always rely on. So let's ask it plainly. How do you navigate this treacherous landscape when the map in your head is useless? How do you guarantee safety when the anatomy is this unpredictable? The answer is a simple, methodical process called the tracing technique. And this is not a suggestion, it is a non-negotiable safety check. First, you identify the vessel you think you need to cut. Second, you put the instruments down. You do not clip it. Instead, you carefully, painstakingly trace its path all the way to the gallbladder wall. And third, the most critical step, you confirm with your own two eyes that it actually ends in the gallbladder. Which brings us to the golden rule. If you take away only one thing today, make it this. If it doesn't end there, it's not cystic. It's that simple. If the artery you're about to clip just keeps on going past the gallbladder, it is the wrong one, period. It's almost certainly the RHA, and you must not cut it. This principle is the ultimate safeguard. You know, this whole mindset of assuming variation until proven otherwise, it's really a cornerstone of surgical safety. So I'll leave you with a final thought to chew on. In the huge, complex world of surgery, What other normal anatomy can't be trusted?